Hi, everyone. This is Rebecca Spicer, and I will be your moderator today. Welcome to our webinar on partnering for child safety, the Fatality Review teams, and state Title V programs. While you're waiting, if you would take a look and participate in the polls in our screen. First question is, do you participate in child death review? Yes at the state level, yes at the local level, both state and local level, and the fourth option is no. We have a second poll question that you'll see on your screen. Do you participate in fetal and infant mortality review? Same answers. So if you, since you have some time and you're just waiting for everything to start, if you could fill in the poll questions, that would be great. Hi, everyone. Welcome to our webinar today. We have a few minutes, and you might see that we have two poll questions in our screen. The first one is, do you participate in a child death review? And we've gotten a number of responses. About half of you currently do not participate in a child death review, but nearly a quarter do at the state level and another 20% or so at the local level. And the second question is, do you participate in fetal and infant mortality review? And the answer there, a good 2/3 of you do not, but I do see that 27% say that they participate at a local level. So if you haven't already filled out the poll questions, go ahead and do so. And we have about 3 minutes, 2 minutes until the start of our webinar. Again, welcome everyone. If you haven't already participated in our polls, there are two poll questions. We will get started in just a minute though. Hi everyone. Welcome to today's webinar, sponsored by the Children's Safety Network. It's partnering for child safety, fatality review teams, and state Title V programs. My name is Rebecca Spicer, and I'll be your moderator today. I'm a senior research scientist at Impact Research in Columbia, Maryland. And we are a member of the Children's Safety Network Alliance. The Children's Safety Network is a project supported by the Health Resources and Services Administration, HRSA, at the U.S. Department of Health and Human Services under the Child and Adolescent Injury and Violence Prevention Resource Centers Cooperative Agreement for $5 million with 0% financed with non-governmental sources. This information or content and conclusions are those of the author and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA, HHS, or U.S. government. Kate will give you a few technical tips.
Thanks, Becky. Hello, everyone. If you can hear me right now, you'll notice that the audio is being broadcast through your speakers. Your audio is only as good as your internet connection, so if you're hearing choppy audio, please look for a more stable internet connection. If you're experiencing audio issues, you can dial into the phone line at 866-835-7973 and mute your computer speakers. Just note that you will be muted on the phone line for the rest of the webinar, and you should ask your questions through the Q&A pod that's on the left. We'll be doing all of our questions at the end of the webinar. At the top of your screen, you'll see a file share pod with today's slides in it. You can download the slides from there. And this session is being recorded and will be posted to the CSN website within 2 weeks. Back to you, Becky.
Great, thank you. So today we have two speakers. Abby Collier is the director at the National Center for Fatality Review and Prevention, a program of the Michigan Public Health Institute. And in this role, Ms. Collier leads the National Center in providing technical assistance and support to local and state child death review and fetal infant mortality review programs throughout the United States. And our second presenter is Karen Nash. Karen is the project manager of the Children's Health Alliance of Wisconsin, where she works to reduce the burden of injury and fatality to young children and young adults through leadership of Wisconsin's Comprehensive Child Death Review Program. So we are excited to welcome our two presenters today, and we will start with Abby's presentation. Abby, I'll just forward to the first slide. There you go, and you can take it from here.
Great. Thank you so much, Becky. It's so wonderful to be here with everybody today. As you've heard, I'm Abby Collier, and I have the honor of directing our center. Much like Children's Safety Network, we are funded by the Health Services and Resources Administration, and what I'm going to share with you are the opinions of me as the author, not of the federal government. Karen and I have three goals for our presentation today. The first is to provide an overview of what child death review is, what FIMR is, and how we collect our data. The second is to identify how to collaborate between your Title V program and your Fatality Review program. And then most excitingly, Karen is going to share an example of what this collaboration looks like in Wisconsin. One of the key things I want to point out to all of you today is that at the National Center, we provide a lot of resources for fatality review teams. That includes training and technical assistance, both in person and virtual. We maintain a data system, which I'll talk a lot about in a little while. But we also have a wide breadth of resources, everything from training modules to written guidances, newsletter, etc. While Title V is not the main audience for many of these items, they would still be pretty relevant to the work that you do. So if you're not familiar with the center, I would encourage you to check out our website and follow us on social media to see what information is out there. And we're always happy to help support public health in any way that we can. Today I'll be talking about our work at the National Center that really focuses on the orange boxes, these bright orange and bright blue boxes. But I want to remind everybody that when we start to talk about fatality review, there are a lot of moving parts. Many communities have several fatality review programs. Some are coordinated, some are not. And it's important to think of this work as a web. And so we should all be connected even though we're doing our own work individually on specific topics. The more connected we are, the more we can leverage resources. So with that little overview of some of our guiding principles, we hope, as I jump into this next part, to provide just that quick and dirty overview of child death review, fetal infant mortality review, and our data system. One thing I want to point out is that every state operationalizes the information I'm going to share with you a little bit differently. So child death review in Nevada might look very different than child death review in Colorado. And for states that have local child death review teams, a state like Wisconsin or Indiana, there's variability in how those local teams conduct their work. So I often joke that when I'm asked about my job, I always answer with it varies. And while there is variability in the work that we do, there is also a common goal. So if I'm sharing something today and you participate in child death review or fetal and infant mortality review in your community and it doesn't align, it doesn't mean your community is doing something wrong. There might be a better way to do it in the community that you live in. One of the questions we often get at the center is, why should I support or participate in child death review? Everybody's plate is full. We're all tugged in so many directions. We really think that there's kind of 5 key benefits to anyone participating in child death review. First is to identify how the number of kids in your community that dies. It seems like this would be really straightforward, that we should know the number of kids in our community who die, but unfortunately, it's actually pretty complicated. So in order to really address the issues around fetal, infant, and child mortality, first we have to know who died. The next is we see improved agency communications simply by bringing people together. Normally I say around the same table, but right now we'll say in the same Zoom meeting. We see agencies who've not worked together begin to build relationships, begin to strengthen collaboration. We also see, as those agencies begin to get to know each other, they can work together more fully. We also experience, as they get to know each other, they start to leverage their resources. The next benefit is we see how agencies respond. I like to think of our communities as sort of a puzzle, and each agency, as they respond, is filling in a piece. And sometimes there's overlap, sometimes there's gaps, but through fatality review, we can get that full picture of how our systems move and work together, so we know where to make adjustments, where to highlight success, etc. The next benefit of participating in fatality review is the opportunity to identify systems improvements. You'll probably hear me say a number of times that the goal of fatality review is to look at systems. I'm repeating it on purpose. In looking at how the systems work together, you're able to identify barriers, risk factors, and trends. And all of that information can be used to write recommendations that are applicable to your community. So as I talk about community, in some places that's a state, in other places that's a county, in other places it's a defined region. So think about what your community is and apply that lens as I'm talking. When you're able to take the data and the findings at such a specific level and then write recommendations, you can make change that's incredibly impactful in your community. And then the last benefit of participating in Fatality Review is the opportunity to advocate for change. It's the opportunity to be the catalyst for improving how systems work, how families can access care, and ultimately how to make your community a healthy, safe place where all families can thrive. We think of sort of two key elements of Fatality Review, regardless if you're talking about child death review or fetal infant mortality review. These two key elements of being multidisciplinary and prevention focused are really what keeps Fatality Review teams successful. I've been doing this work for about 14 years now, and in that time, teams that embrace these two principles are automatically successful. By bringing people to the table and staying focused on prevention, they're able to identify how to improve their community. So I'm going to jump into an overview of what child death review is. So we think of child death review as an opportunity to understand how and why kids die. Again, every state sets their own case criteria, but most states review any child younger than age 19 who dies. These multidisciplinary reviews typically consist of a medical examiner or coroner, law enforcement, local public health, a pediatrician or someone familiar with child development, the child welfare system, and the legal system like a prosecutor. Again, states and communities set their own parameters around who sits at the table, but that's sort of the gist of what we would consider to be a core team. This multidisciplinary group of people come together to share information, and they do that by sharing case-specific information, so going through Johnny's life, the incident causing death, what happened, and then after, anything that happened after. Again, CDR teams illuminate where systems are working together very well and where there are opportunities for improvement. And I want to point out that sometimes those opportunities for improvement as we think about systems are not because someone's doing something wrong or a system isn't functioning. The system might be functioning the way it's supposed to, but that way either needs to be updated or needs to fit differently in the context of the broader community. Fatality Review is a very unique opportunity to look at disparities in how families are offered resources, how they access them, and how they navigate systems. It's also an opportunity to understand how families navigate through complex systems like child care assistance or accessing something like food stamps. It's a great opportunity to hear the voice of the family. Lastly, and I've said this a number of times already and I'll continue to say it, is that child death review work is prevention work. If you would have told me this is where I was going to hang my professional hat, I might have said no thank you. But knowing that the work is focused on prevention, it's focused on keeping kids safe, really makes this worthwhile. A key question we ask ourselves in child death review is, how does this contribute to prevention? And so that's really the guiding philosophy. I'm a process person. I like to know how things are going to unfold. So what you see is kind of a basic idea of how cases move through the child death review process. So there's case selection, members bring their records, they have a discussion, and as you can see, they do data entry, and then action happens. I'm going to transition now to talk about FIMR, which is Fetal and Infant Mortality Review. FIMR is a similar process to child death review. except it looks at deaths from about 20 weeks gestation until the first birthday, and also includes stillbirths. FIMR follows a little bit of a different process to get to where they're going, and I'll share that with you next. FIMR is not nationwide like Child Death Review. It's in 28 states and Puerto Rico, and there's about 161 FIMR programs. So while we have Child Death Review comprehensively throughout the U.S., FIMR is active in these 28 states. So this is what the FIMR process looks like, and you'll notice sort of a key difference right here, right in the beginning. Case selection happens, and then there's sort of this two-part path forward. The first is that the records abstraction happens. Instead of team members bringing information to the table, somebody goes and does records abstraction. The second thing that happens right there is that there's a family interview. So in FIMR, the FIMR process, there is an opportunity for families to connect with an interviewer and share how they received care, how they felt they were treated, what their life looked like, etc. Both those two pieces, the records and the family interview, are put in a case summary, and then the case moves through the process. I want to talk for just a minute about data collection before we jump into some new resources that have been created for the Title V community. The National Fatality Review Case Reporting System, or Case Reporting System for short, is our web-based data system used both by Child Death Review and Fetal and Infant Mortality Review teams to collect comprehensive information about the child, the family, the supervisor at the time of the incident, as well as the investigation and any outcomes. The case reporting system notes specific risk factors related to the cause of death, provides a place for the team to note their findings and recommendations, and even can be used to record things that impact the quality of review, like lack of records or a team member who couldn't attend. It's a very comprehensive system. Our data form is 25 pages long, and there are a lot of questions that are asked, but the unique data you can get out of Child Death Review or FIMR will be highlighted in just a moment. So if we look at the case reporting system, we get about 70 new cases a day, so 60 in our Child Death Review bucket, 10 in FIMR. There's about 2,500 users total. As you can see by the number of variables, we sum it up by saying there are a lot, and we have about 240,000 cases in the case reporting system. So this data, these data that I'm going to share, are really grounded in a large number of cases. These are the states using the case reporting system. You can see it's pretty widely adapted with a few exceptions. And if you're from a state that's not colored orange, know that your state is working on it. I want to point out that every state uses the case reporting system differently. So some states might use it in all communities, other states might use it in one, which makes these data a little bit difficult. I want to move in now to talk about some resources that we built to support collaboration between Child Death Review and Title V programs. If you look in the links pod at the top of your screen, you will see a link to our website, and these resources are highlighted right at the top of that page. Our team worked together with many folks at the state and local level, as well as our federal partners, to build 3 resources related to the national performance measures. I'm going to talk about the resources related to maternal smoking and adolescent mental health. Karen will be sharing some of their work in Wisconsin related to infant safe sleep, so I'm not going to touch on that, but there is a guidance for that. We see at the National Center great opportunities to collaborate with Title V and Fatality Review. We see that through the contextual information that Fatality Review teams bring to the discussion. They share so much more than what's on a death certificate. We also collect unique factors related to prevention. There's a wide variety of partners engaged in child death review, so it's a place to hit a good breadth of partnerships, you know, everything from district attorneys to your coroners to your schools. And as I mentioned earlier, it's really a unique opportunity to understand how disparities are present in your community. And I know for many of us, that's particularly important right now. So I'm going to start by talking about some of the findings from our adolescent mental health guidance. And again, you can access the whole guidance. I might be a little biased. This is an area that I have education in. I've done some research, but this work really highlighted some interesting opportunities for prevention. So we took all of the cases that met our case criteria and we divided them into the 3 buckets you see on the screen. The first bucket was children who died of an accident, homicide, and they had no documented mental health history in the case reporting system. The second group of kiddos was this group who died of an accident or homicide, and they did have a documented mental health history. And the third group were young people who died by suicide. We further took these groups and divided them into 2 age categories as recommended by the American Academy of Pediatrics. When we looked at the data, this is sort of how we presented it and how we saw it. You see your 3 buckets across the top, and each bucket further divided into 2. When we looked at basic demographics, age, race, ethnicity, it all was pretty consistent with what we expected. More males than females, and while the numbers showing non-Hispanic white being the highest number of children that had died. The next slide will start to get into how child death review tells us unique information. So here we collect information about the child's history as a victim of maltreatment, the family's history with child welfare, history of abuse and neglect, and problems in school. And so if you're looking at these data, you can see that the numbers are here, but if you pay attention to this middle group, this group that had a history of documented mental health needs, their numbers are substantially higher than the numbers in either of the other 2 groups. And so from a prevention perspective, this is a great opportunity to look at how your community could dive in to this work and build prevention work around these families. Oh, I advanced it. Here we go. Sorry, I'm having a weird advancement problem. Here you can see we also looked at if the child had a history of delinquent or criminal behaviors, and one group in particular sort of really stood out as having a higher number, which is this sort of middle adolescent group with a history of mental health needs. Could go much deeper into the data, but I hope that by giving you this sort of snippet of data from the guidance, I piqued your interest in that you're going to go click on the link and go check out the guidance. You'll also find in there some information about how to connect and how to collaborate. I'm going to highlight just a little bit from our guidance on smoking, which we found that 1 in 14 women who give birth in the U.S. report smoking during pregnancy. And FIMR teams really provide that avenue to understanding more about how and why. And so when we dug into our data, what we found was that, a low percentage of parents reported getting education about tobacco during their first prenatal visit, during hospital admission and discharge. We also found some interesting data related to how families were being referred to social services and what percentage of that was related to smoking. But maybe what we found to be most interesting was this here on the fourth bullet, which is mothers who smoked during pregnancy reported higher rates of financial problems, involvement in physical fights, having someone close to them experiencing a substance use problem, and experiencing physical abuse. When we look at that data, again, that data really tells us a great deal about how to support families and where our opportunities for prevention might lie. I know I've sort of sped through these pieces in a way that maybe tells part of a story, and that was intentional. We hope this data piques your interest and you go and look at the resources that were created. We know 48 state Child Death Review coordinators report collaborating with Title V, and that's amazing. We'd love to see that number continue to grow and those relationships deepen. I often think of our work on Child Death Review as sort of identifying the problem, writing the findings, and the work on the Title V side as doing the prevention work impacting the families. So that is our contact information to the National Center, and as always, it's such an honor to be here with all of you working for this joint goal of healthy, safe communities where kids and families thrive. So thank you.
Thank you so much, Abby. I want to remind everyone that you can continue to ask questions if you haven't noticed at the bottom left of your screen. There's a box where you can enter questions, but we will be answering questions after Karen's presentation all at once. So hold on for that. And I will welcome Karen now to present her piece on the Child Death Review. Go ahead, Karen.
Thank you. Good afternoon, everyone. My name is Karen Nash. I am one of the staff persons, a project manager at the Alliance, who works to support our injury prevention and death review initiative, which includes a number of activities formed under the Keeping Kids Alive program, which also houses our comprehensive death review system, which I'll be speaking of today. So just a little bit of information about our organization. So at the Alliance, we advocate for children's health. We fall under the Children's Wisconsin umbrella, but we do not have the Blue Kids logo. We look like, act like, sound like our own 501c3. So our primary focus really centers around advocacy, building partnerships, and influencing health policies and practices that really promote the health, safety, and well-being for all Wisconsin children. The icons you see on the slide are the 6 key initiatives that we work on. We do not provide any direct services except for our outreach to families who have experienced a sudden and unexpected infant loss, which I'll talk about a little bit later. Our primary role is to really provide that support and be a resource to professionals who do provide direct services so that they will help them to better serve and support the children and families under their care. Just some historical facts, we were created 26 years ago by the Wisconsin Department of Health Services under the Family Services Health section. We were created using Title V and CH funds. And from the very beginning, our focus was to be on kids, since the bulk of health initiatives were already primarily focused on adults. And so our focus was to be on children and then also those in underserved populations. And our role was really to be in a position to affect systems change and public policy and building partnerships among common and uncommon partners And that's where the state really identified the need to create an entity that sat outside of government that could work to make a change and do so while working across the state with all partners, even those who were considered competitors. A significant portion of our funding comes from DHS, which is a pass-through of a number of federal dollars, MCH, CDC, and HRSA funding. We also receive direct funding from organizations like the CDC, other academic institutions, and some private funding. So in the early 2000s, the Alliance was charged by DHS with creating a comprehensive CDR system as a part of their MCH priorities. And back then, Wisconsin was one of a handful of states that did not have a comprehensive death review system. And here's an example of where DHS felt that a fatality review system would be better built with our organization, pulling those partners together rather than a government entity. So our system in Wisconsin is voluntary, so for the counties that participate, there's no state mandate or legislation. This work is all done as a result of county-based efforts, much like many of the services that are provided in Wisconsin. We have a long-standing history of practices and services that are led and delivered by those closest to the people being served in those communities. So while we worked a little bit behind the scenes on that work, we, in 2006, were awarded some funds to kind of build upon what we had already started doing in the creation of this comprehensive death review system. And at that time, there were around 10 CDR teams functioning in some capacity. And we now have more than 50 teams out of the 72 Wisconsin counties, and all have been trained by the Alliance to follow our Keeping Kids Alive model. And the colors on this map simply indicate which Alliance staff person is providing technical assistance to that team. Our program is modeled after the National Center for Fatality Review and Prevention, which we know is focused on prevention and not blame. And so we know that what we learn from CDR really drives those broader social and public health policies and other issues. When we were created, DHS understood that local teams would need support, and we would act as technical assistance for teams that were created. We knew that there needed to be champions to really enforce the collective good state, a backbone of support to ensure that the continuity and integrity of the process would remain. And so DHS made the decision to allow local health departments to use those Title V MCH funds to create CDR teams and staff them knowing that the Alliance would be serving in that role as technical support. The philosophy and strategy was to get those teams formed and create that buy-in from the local level that would have sustaining power after the funding ended or shifted. And so once those teams were established, DHS was able to direct funding to be used at the local level for prevention, such as unsafe sleep. And not necessarily to direct service to clients, but rather to build those partnerships and infrastructure with those who were directly already working with families, so hospitals, daycare centers, home visiting programs, and other community agencies. Counties, like many others in Wisconsin, vary in size and the number of deaths that they had. And so it was and still is really important to have someone or an entity like the Alliance always pulling together that statewide picture or impact. And so teams could really learn and understand from one another what was happening and really feel like their little piece was contributing to that larger prevention or public policy effort. And so it took us about 10 years to build this system. And our goal now and going forward is to really maintain a strong infrastructure and provide that ongoing training along with promoting prevention and building and sustaining those partner relationships. Benefits of CDR, Abby touched on many, but it's really to encourage that collaboration with key partners, promoting that systems level change, raising awareness about those really important issues, using your data to highlight the burden of that injury, and then really put some things into place to drive that preventive action. So the work that we've done in Wisconsin has really spread and created that collaboration among many partners across the state. And so it's allowed us to build trust, share information with one another, and really grasp that greater understanding of the different roles each agency plays in the lives of families. We were able to build a relationship with our WIC program so they could be champions for safe sleep. FIMR has brought together many partners who've worked to influence hospital efforts around prenatal care and other infant prevention topics. Law enforcement agencies who participate in CDR have changed protocols or investigative procedures because they've learned a little bit more information at meetings and have created those relationships with uncommon partners, such as working with hospitals to advance their car seat checks, things like that. And so CDR has really given local counties a platform for those folks to really come together. And we know that in a lot of communities, folks don't always play well together, even though they're, in the same county or system or working in the same organization. But after participating in Child Death Review, they really find the value in each other's work and begin to understand how working together can positively impact the families they serve. Ideally, the data would be used to drive that prevention, but in addition to the data, CDR drives those conversations and raises the awareness, which is really beneficial to understanding, again, that bigger and broader picture, and that is what really drives that action. So CDR can be a catalyst for change, especially when it is supported by that data. So the CDR team really influences the prevention, as Abby mentioned, and as I'm sharing with you right now. So, the sharing of information among partners and how that data is transformed into useful information and analyzed. And so teams are really able to identify what those protective factors are and help to prevent similar deaths in the future. Again, it's created a way for us to really have a picture, a good solid picture of what deaths are happening in the community. And it allows us to tell the story in a way that's meaningful, and you can really identify the impact on families. It also gave us an opportunity to really learn how to have those conversations with our policymakers about why resources for prevention were needed. And the safe sleep example is a really excellent example. So that are reviewed, and it's really difficult to understand the causes of those deaths, especially when it's related to sleep. So was it because mom didn't have a crib? Were drugs and alcohol involved? Was it that education on safe sleep was not being provided? Whatever those questions were, CDR really helped us to answer those questions. And so this also helps us to understand other issues that might have been going on with the families, such as any other kind of social factors that we needed to be aware of. And so we were able to collect data and not only learn that babies were dying, but learn how they were dying. The Sleep Baby Safe is a great example that we like to share that really highlights our collaboration with DHS to create a prevention, very needed, much needed prevention in Wisconsin. And so this activity derived directly from reviewing infant death cases in CDR. And so Sleep Baby Safe is a suite of trainings and resources developed by the Alliance in partnership with the Department of Health Services. And these resources were created to be used by a variety of professionals who talk with families about safe sleep. And professionals who attend the training will learn the American Academy of Pediatrics, what the safe sleep recommendations are and the why behind them. They'll also learn how to best have those conversations with families about safe sleep and begin to help families create that plan of care. And they'll also be able to review the most up-to-date data that will help them tell that story about what's happening statewide. This is kind of a lead-in to our presentation or our training when we're working with professionals. We all remember when safe sleeping, co-sleeping received a significant amount of attention about infants dying in unsafe sleep environments. And so at that time, we learned through a number of focus groups that families were hearing, they were receiving mixed messages about what exactly is safe sleep and how were they supposed to sleep their babies. And this information was coming from medical professionals, family members, and friends. And so it goes without saying that professionals really wanted to share a common and consistent message about safe sleep, but they may not have felt comfortable doing so or simply just didn't know how. And while there were public campaigns to spread that safe sleep message, we recognize that public campaigns only reach so far, and families had very real circumstances that often dictated where and how they would be able to sleep their infant. And so we monopolize on the strong and trusting relationships that many professionals already had, and we're in a position to have a conversation with families rather than to promote a campaign. And so our hope was, and still is today, that this work is embedded in public health and home visiting programs throughout our state. And in fact, this past year, the Wisconsin Department of Children and Families added trainings on safe sleep as a requirement for all of their home visiting programs. And this Sleep Baby Safe training was one of the recommended curriculums. And so this all came out of the work that started with CDR teams reviewing those cases and collecting the data. These are the objectives outlined here, the three main components of the training. One of the most important components, and one many attendees share that they find extremely valuable, is the discussion and tips on how to best engage families in those conversations about what's the best and safest way to sleep their baby. How do they create a safe sleep environment? Overall, the goal for this training is to equip professionals with the tools and the resources. Oh, did I advance? My apology. With the tools and the resources that they're able to build that confidence and have those conversations with families and really help to guide them on how to incorporate those tried and true safe sleep practices into their infant sleep regimen. We've created a number of resources for professionals to use throughout their education with families on safe sleep. Again, the trainings, there are several versions of the trainings which are targeted to specific professional groups. There's one for child care providers, medical providers, parents and caregivers, and just simply general professionals working with families. The resource at the top, the Teal Blue booklet, is a conversation guide. It's a handheld resource professionals can use while they're having the conversation with families and highlighting some of those more important concepts covered during the training. This is not a resource to leave with families, though. So this is just something that can aid in that conversation. The Red Book really is kind of a refresher notebook for the worker, so they can review the content before actually walking into the house with mom and just making sure that they're reiterating some of those important points from the training. And then the resource on the right is the table talk sheet. It acts as a visual aid for professionals to use during that discussion with families, and it really lays out kind of what those important points are of safe sleep and hitting on the AAP recommendations. And the table talk sheets are available in several ethnicities and languages, and this is something that can be left behind for the caregiver to keep to remind them on what safe sleep is. Also, child care providers are able to receive CEUs after attending the training. We have a whole host of other resources that we can share that are available on our. The final resource we're able to offer families is grief and bereavement support through our Infant Death Center, which is written into Wisconsin statute. So the IDC was established in 1980, and it's a free resource to families and professionals who experience a sudden and unexpected infant death. So families who experience the death, and then also professionals working with those families. And so it's particularly offered to families who lose an infant in the community. A lot of hospitals have system bereavement support already in place. And so upon notification of the infant death, we reach out to those families to assess their needs, and we follow them for a full year with a of things, phone calls, mailings, text messages, things like that. So I'll just close with this and just say that we by no means in Wisconsin have this all figured out. We have a lot more work to be done. Again, we don't have legislation authorizing fatality review, but we are working on it. We have our health departments who are under siege with COVID and CDR teams that haven't met for most of the year. But the important point here is that we are still here to support those teams and uplift them in any way that we can in other areas of their work. And so, like many, we have a long way to go to really influence those systemic responses to infant mortality in our community. But we know that CDR is really a strong and viable way to inform and influence those broader topics under maternal child health. And so the death of a child is so very tragic. And I'll just leave you with this quote from our past State Council Chair, Dr. Perloff, who always said that we owe it to the child and family to at least have a conversation about what happened and why, and learn from it so that we can make sure that it does not happen again. I will turn it over to our moderator.
Great, thank you, Karen and Abby, both of you. And we actually have a lot of great questions. I have my job cut out for me. So why don't we jump to the questions, and while we're doing that, a reminder that you all can go ahead and type any additional questions into the box at the bottom left of the screen. So with no further ado, I will start with a question for both of you. Can you give a real-world example of where data has encouraged a partner to change a practice or policy?
This is Abby. Sure. I can think of a number of states that have modified their life jacket distribution as a result of what they found in child death reviews. So either implementing something like a life jacket loaner board or changing regulations related to boating. I can think of another example where a community put lifeguards at a specific beach following a series of deaths And then states that have changed legislation related to their graduated driver's licensing laws is another one.
Yeah, in Wisconsin, we have similar local examples. One really, I think, interesting or important example is that we, in one community, noticed that there were a number of drownings that really impacted the Hispanic community. And so it was learned that the signage in the community was only written in English, and so that gave those local folks an opportunity to use that data and create some signage and put up next to that pond to so that, you know, Spanish-speaking families were able to read that it was a danger.
Great, thank you. So another question that came across the boards is on the sharing the messages with others. Have you experienced culture as a barrier and difficulty with parents gaining adherence from family members who are caregivers due to different strong cultural beliefs?
Yeah, I think the Safe Sleep is a really good example. In our focus groups, we learned from a number of different demographic groups that elders and their families really dictated how they would care for their babies, and cribs weren't needed, or we didn't use those, and you slept on your stomach and you were fine. And so we really equipped those folks with actual conversational tips that they could use with those families. And they're actually, I can share these at a time with the group, but we have, what do you call those, when you kind of do a skit or play, where you kind of are learning the professionals, like one person is pretending to be the parent
scenario.
And the other person. Yeah, we have those different, thank you, these scenarios where professionals can really practice on how to answer those questions that families have. It's about being advocates for your child. We just got a phone call the other day about a mom wanting to know how does she have a conversation with a child care provider. And I said, well, your main goal is to make sure that your baby comes home with you at night. And so you want to do all you can to advocate for their safety. And they don't have a voice right now, so you are their voice. And so don't feed into the first time, jitters of being a mom and you're overreacting. You do want to overreact because you want to bring your baby home.
Great, thank you. So let's see. Here's a big picture question. What is the best way to work with child death review teams for changes in policies such as seatbelt use, child passenger safety, and improvements to graduated driver licensing laws? And actually, maybe on top of that, a similar question is, if someone wants to know what's going on in their area with respect to child death review or fetal infant mortality review, who do they contact?
Those are both great questions. I'm going to pop the link to our website in the chat. If you go to our website and click either on child death review or on fetal and infant mortality review, you'll see a button for map of programs. Click on any state you want to know about. It'll give you key contact information, some facts about their state, reports if we have them, etc. So it's a nice place to go to get an overview. So I would recommend starting there. If you would like additional information, certainly you can reach out to the person listed on that website. You're also more than welcome to reach out to us at the National Center. We have pretty constant contact with our state and local teams, so if you're wanting to know something and get connected, please let us know. As far as how to, use or leverage Fatality Review to make some of those systems changes, the first thing I would say is look at the data, have the state or community dive into the data. If they need support doing that, we certainly can help them with that. And then take those data and pull together stakeholders to write recommendations. And the recommendations can center on policy change. This is a technical assistance option that our center provides to states. So if this is something that your state is interested in, I'm not sure what state you're from, but we'd be happy to connect with you and the CDR leadership to see how we can help support that process. I think I answered them both, Becky.
Great, thank you. And I have another question that's more specific. Is there anything as a law enforcement officer, so this comes from Lindsay Adamson, is there anything as a law enforcement officer data collection-wise that could be given or sent up that could help the review boards for their states that have them? Is that question clear?
Yeah, the question's clear, and it's a great question. So I think anytime there's the opportunity to use a standardized death scene investigation form, and we actually have a number of them on our website, the more successful the review is going to be. Not only does it provide a lot of detail, but it also provides a lot of consistency, so all families are treated the same. There's one for infant deaths, there is one for children under age 5, and then there's some topic-specific ones like children who die by suicide or in a motor vehicle crash. So if you're not familiar with them, if you visit our website, many of them are there. You're also welcome to send me an email.
Great, thank you. I'm going to ask one last question because there are a couple questions on Native Americans and getting data on Native American child deaths. But this specific question is, do you engage directly with any tribes regarding the Safe Sleep program? And if so, how did that go? So this will be the last question.
Karen, do you want to answer that for Wisconsin?
Yeah, so we do. They actually were really helpful in helping us to put together the resource for Native American families. And so we already had relationships through some of the other work that we were doing, and a lot of them were already partnering with their health department in some way, shape, or form. And so it made it really easy to leverage that relationship. And then when they learned that we were making a resource specific to that demographic, they wanted to make sure that we had the best information possible, and so agreed to be those resources for us.
Great, thanks. I think we have one more thing to wrap up before we wrap up. In the meantime, you can see that we have an upcoming webinar, and here's a link if you want to register for the webinar, Farm Safety for Children and Youth, Risks and Rewards. Hold on just a second, everyone. We have one more thing we wanted to mention before we wrapped it up. And while we're doing that, I just want to thank Karen and Abby so much for their presentations. That was really great. And everyone on the webinar, you'll see that there'll be a link to evaluation for today's session, and you'll be able to fill that out when you're done. Here we go, and you can see the evaluation now if you want to go ahead and fill that out.